Welcome to the debate. In a building, a cracked foundation is, well, it's a straightforward problem. You look at the concrete, you test the load-bearing columns, and you know exactly what you are dealing with.
Right. If a beam is cracked, you replace it.
Exactly. But when that foundation is an elderly patient's femur, and the steel implant wedged inside it might still be perfectly stable, the math changes completely. I mean, do you wrap the cracked bone in wire and hope it holds, or do you rip the whole metal beam out and start over?
That is honestly the absolute perfect way to frame it. You are stepping into the diagnostic muddy waters of total hip replacement surgery. You are working with a shattered biological structure and trying to decide in real time if the house can still stand.
And that is exactly what we are exploring today, the management of periprosthetic hip fractures, specifically what the literature calls Vancouver-type B1 fractures. The Vancouver classification dictates how we treat these fractures based on where they are and, crucially, whether the implant is stable.
Right.
A B1 fracture happens around a femoral stem that is supposedly still firmly fixed in the bone. So, when facing this exact scenario, do we prioritize preserving the existing implant with less invasive fixation strategies, like cerclage wiring, or do we lean toward definitive revision arthroplasty to mitigate the severe risks of implant failure?
It's a massive decision. We're looking at the latest clinical studies, registry data, and surgical standards regarding fracture classification and post-operative mortality to really parse this out.
That less invasive fixation strategies, like cerclage wires, offer the absolute optimal recovery path for these B1 fractures.
And I argue that the sheer difficulty of proving true implant stability justifies a more aggressive reliance on revision arthroplasty, to prevent catastrophic failure down the line.
Let's get right into the realities of what we're actually treating here, because we aren't just treating a broken bone, right? We are managing a physiological ticking clock.
Absolutely.
The patients we see with these fractures are often elderly, dealing with multiple comorbidities. The data on mortality isn't just a statistic. It's a harsh physiological reality. When you look at cohort studies linked to the National Joint Registry, high-risk patients, like males over 75 with higher ASA grades, face up to a 60% mortality rate at 5 years following a revision for a periprosthetic fracture.
Wow, that is a staggering and, frankly, sobering reality.
It is. A full revision on an 80-year-old isn't just a slightly longer surgery. The massive blood loss, the extended time under general anesthesia, the physiological shock of ripping out an implant, it compounds into a systemic hit that more than half of these patients simply won't survive over the next 5 years.
Right.
Which is why our primary directive has to be minimizing surgical trauma. Preserving a stable construct using targeted metal wiring to stabilize the bone provides the safest, fastest path to immediate weight bearing. And the clinical data supports this. The Rocky retrospective cohort study showed a 99% reintervention-free survival rate at 6 months when using cerclage wires for intraoperative B1 fractures. We avoid the massive hit of a full revision and, well, we get them walking.
I mean, I am entirely sympathetic to wanting an 80-year-old off the operating table as quickly as possible. I really am. But the absolute tragedy is when that quick fix fails 2 weeks later. Relying on fixation alone is a dangerous gamble because, honestly, intraoperative stability assessments are inherently unreliable.
Unreliable?
Yes. What we often diagnose as a stable B1 fracture is very frequently an unstable B2 fracture in disguise.
But you are assuming the diagnosis is always wrong.
I'm assuming human hands are fallible. I mean, if you misclassify a loose stem as stable and just wrap it in wire, you are guaranteeing mobilization of that implant. It will fail. And then that fragile patient needs a second, even more traumatic surgery when their physiological reserve is completely depleted.
I see your point.
And this is exactly why I advocate for techniques like cement and cement revision. You use a long stem to bypass the fracture site entirely by at least 2 cortical bone diameters. Yes, it takes a bit longer up front, but it provides guaranteed biomechanical stability.
Guaranteed?
Look at the Bryant Evans study of 23 patients using this exact method, 0 cases of stem loosening at a 3-year follow-up. You do it once, you do it right, and you ensure that vulnerable patient never ends up back on the operating table.
Okay, if the consequences of a loose stem are that severe, the mechanical solution we choose definitely has to be bulletproof.
But before we can even select the solution, we have to talk about how we diagnose the fracture type in the first place. You mentioned that human hands are fallible, but I think you're underselling the rigor of standard intraoperative testing. Surgeons don't just look at the stem and guess.
Well, no, of course not. They apply significant vertical and rotational preloading stress to the implant, right there on the table.
Right. They grab the implant and physically try to twist and push it.
Yes, and if they stress the joint and the vertical and lateral offset align perfectly with the preoperative measurements and the digital templating, stability is empirically confirmed. The implant isn't subsiding, meaning it's not sinking deeper into the femoral canal, and it isn't rotating.
But is that enough?
I see why you think that, but let me give you a different perspective. Isn't applying physical rotational stress the most empirical test available? It is exactly like load testing a structural beam in real time with actual weight, rather than just relying on a blueprint. If it resists the rotational torque applied by the surgeon, the bone stock is physically proving it can hold the implant.
I'm sorry, but I just don't buy that comparison. A structural beam in a building isn't subjected to the biologic remodeling of human bone. And the physical forces applied by a surgeon's hands in the OR are a tiny fraction of the cyclical loading that the hip will endure the second that patient stands up and puts their full body weight on it.
Well, sure, the body weight is higher.
Let's look at the mechanics of how these fractures actually occur. According to the German Arthroplasty Registry, intraoperative fractures occur 14 times more often around uncemented stems.
Which makes perfect sense given the press-fit technique used to implant them.
Exactly. You are wedging a titanium wedge into a rigid biological tube, the femur. Until it's tight enough to hold, the fracture happens precisely during broaching or implantation, meaning the mechanical force of the titanium wedge causes the bone to crack to relieve the pressure. The bone-implant interface is inherently volatile at that exact moment.
Right.
Human hands simply cannot consistently detect micromotion at that interface. We are talking about fractions of a millimeter here. If you miss a single millimeter of subsidence or a fraction of a degree of rotational micromotion, you are leaving an unstable stem in the femur. And the Swedish hip register data shows us exactly what happens. Historically, 8% of these supposedly stable B1 fractures require further operations because the initial assessment was wrong.
But wait, if you are performing a primary total hip arthroplasty and the stem is placed optimally before the calcar cracks, the hoop stresses have already done their primary work.
Let's clarify hoop stresses for the audience really quickly.
Sure. Hoop stresses are the outward radial forces created when you drive a wedge-shaped implant down into the tubular bone. It's the tension in the bone that keeps the implant wedged tight, exactly like the metal bands holding together a wooden barrel.
Right, a great analogy.
If the stem is seated and those stresses have achieved press-fit stability before the fracture occurs, you are testing the actual construct in its final position. If it holds, it holds.
But a fractured cylinder is not an intact cylinder. When you have an uncemented stem, the long-term stability relies on osteointegration. The bone literally has to grow physically into the microscopic porous coating of the titanium implant.
Yes, exactly.
If there is micromotion, because that fracture compromised the initial rigid press-fit barrel, that bone ingrowth will never happen. Instead of bone, the body forms fibrous scar tissue around the implant, which guarantees it will eventually loosen. You are trusting that a cracked barrel will hold water, just because it felt tight for 10 seconds in the OR.
Okay, so if we assume for a moment the surgeon has accurately identified a true B1 fracture, the stem really is stable, the barrel is tight, we have to compare the actual mechanical solutions, wrapping the bone with cerclage wires versus a full stem swap. The Rocky study demonstrated that for true intraoperative B1 fractures, simply utilizing cerclage wires drives Harris hip scores from an average preoperative score of 42 all the way up to 94.
94 is a phenomenal outcome, I'll admit that.
It represents exceptional clinical function. Patients walking without pain, navigating stairs, living normal lives. And the mechanism of why it works is so elegant. You identify the crack, you wrap the bone with the metal cerclage wire to neutralize those outward hoop stresses, and you preserve the existing stem. You entirely avoid the massive trauma of ripping out a seated implant and trying to execute a cement-in-cement revision.
That's a compelling argument for biological preservation, I'll give you that. But have you considered the overall construct strength? The registry data clearly shows that revision stems are vastly superior for overall biomechanical construct strength. A cement-in-cement revision is actually incredibly elegant in its own way. You leave the well-fixed outer cement mantle from the previous stem in place, so you aren't destroying the existing bone interface. Then, you remount the old cement slightly, and you cement a new, longer stem inside that old mantle.
But why is the longer stem so critical?
Because of the mechanical bypass. This longer stem bypasses the fracture site entirely, usually by a ratio of at least 2 cortical bone diameters past the lowest point of the fracture. The stem itself acts as an internal splint, completely offloading the mechanical stress from the fractured bone.
I see.
With a long revision stem, you aren't just trying to neutralize hoop stresses with wires, you are completely bypassing the structural defect. Even in the Cerclage study you cited, they noted a case where a misclassified fracture led to rapid stem loosening that required a massive revision anyway.
I'm not convinced by that line of reasoning because cement in cement introduces severe biological risks. Namely, cement extrusion into the fracture site, which physically inhibits bone union.
But how much of an issue is that, really, if the stem is offloading all the weight?
It is a huge issue. When you pressurize new cement into the femoral canal to hold the new stem, those high pressures can force polymethyl methacrylate, the bone cement, directly into the fracture lines. This does 2 very destructive things. First, the curing cement gets incredibly hot, creating a zone of thermal necrosis that kills the surrounding bone cells.
Right, the heat is a factor.
Second, it creates a permanent physical acrylic barrier between the osteoblasts trying to knit the bone back together. It blocks osteogenesis. Cerclage wires, on the other hand, just encircle the periosteum, the outer layer of the bone. They hold the fragments in compression while allowing the bone's natural blood supply to do its work. You achieve union naturally in 4 to 6 months, rather than hoping the bone somehow heals around a mass of extruded acrylic.
I understand the fear of thermal necrosis and cement extrusion, but the Bryant-Evans study explicitly addressed this mechanism. They found that while small amounts of cement did occasionally escape through the fracture gaps due to the high insertion pressures, it did not actually inhibit fracture healing, as long as the revision stem successfully bypassed the fracture site.
Because the stability overrides the biological barrier?
Exactly. The bypass is the critical mechanism here. Because the long stem absorbs all the mechanical load, the bone fragments are perfectly stable. They are stable enough to heal even if there is some cement in the periphery. In that study, they had 18 fractures heal with radiographic union at an average of just 4.4 months. The only non-union they had was a single case where the stem failed to bypass the most distal fracture line. So the absolute mechanical stability of the long stem vastly outweighs the biological concern of the cement.
But we keep circling back to the systemic toll. Every extra minute you spend reaming out cement, preparing a new mantle, and impacting a long stem compounds the risk of venous thromboembolism, myocardial infarction, and hospital-acquired pneumonia. Cerclage wiring is incredibly swift. You expose the fracture, pass the cables, tension them, lock them, and you are done. The surgical footprint is a fraction of a revision.
I come at it from a different way. If that wire fails because the stem had a millimeter of micromotion you couldn't feel, the patient's physiological reserve is even lower for the second surgery. They've been bedridden, their muscle mass has deteriorated, and now you have to do the massive revision surgery anyway, but in a compromised host. By taking the extra 45 minutes to do a cement-in-cement long stem initially, you guarantee they only endure one operation.
Let's push further into the mechanics of the fixation itself, because even if a surgeon opts for the less invasive fixation approach, which remains my preferred method for a truly stable B1, the debate fractures further. Do we use traditional metallic cerclage wires, or do we use isoelastic cabling?
And this is where the limitations of your fixation strategy really show themselves. Traditional metal cerclage has significant biomechanical flaws. Yes, metal wires with positive locking systems offer great initial axial and torsional stability. You can pull them incredibly tight.
Right, which is what you want.
But clinical data suggests that metallic wiring is associated with a much higher risk of construct failure over time compared to isoelastic cabling.
Because of the rigidity?
Precisely. Metal is utterly unyielding. We have to remember that bone is not steel. Bone is viscoelastic. When the femur flexes during the natural gait cycle, which it does with every single step, a rigid metal wire cannot stretch. It behaves like a cheese wire.
Oh, wow.
Yeah, it can cut right into the osteoporotic bone, or the wire itself can snap under the cyclical fatigue of thousands of steps. Isoelastic cables, on the other hand, are made of non-metallic polymers. They maintain dynamic compression. They stretch slightly with the bone and then recoil, maintaining constant tension even as the bone slightly resorbs or changes shape during the healing process.
But in an ostensibly stable B1 fracture, you do not want dynamic movement. I defend metal wiring as the necessary standard precisely because of that absolute rigid fixation. You want to lock that bone exactly where it is so the press fit of the stem isn't compromised. If you introduce elasticity into the fixation, you are inherently allowing micromotion at the fracture site. And as you pointed out earlier, micromotion is the enemy of primary bone healing and the enemy of uncemented stem osteointegration.
But if you use a perfectly rigid metal cable on a V-elastic biological structure, the bone will eventually yield to the metal. We see this in stress shielding and cortical notching.
Let's break those down.
Sure. Stress shielding happens when the rigid metal takes all the mechanical load, causing the bone underneath it to weaken and resorb because it's no longer being stimulated by weight. Cortical notching is when that rigid metal wire physically digs a groove into the hard outer layer of the bone.
Right.
The isoelastic cable mimics the modulus of elasticity of the bone itself. It provides compression without creating a rigid stress riser that can lead to a secondary fracture right at the edge of the wire. And despite your claim that micromotion is the enemy, the data shows that isoelastic cabling achieves the exact same union rates at 1 year as metal cables, but with a drastically lower risk of catastrophic hardware failure.
That's an interesting point, though I would frame it differently. Think of a suspension bridge. Do you want the absolute rigidity of solid steel, which might snap under sudden force, or the dynamic tolerance of isoelastic cables that can absorb stress? Why would we accept the higher mechanical failure rate of metal if isoelastic cables yield the exact same union rates? The focus shouldn't just be on the initial rigidity on the operating table, but on how the material interacts with the bone's living physiology over the months it takes to heal.
Precisely. And that is why the material science matters immensely if you are going to rely on fixation. But again, it all circles back to the foundation we talked about at the beginning. If you put the most advanced, perfectly modulus matched isoelastic cable in the world around a femur that holds a stem that is micro-moving by 0.5 millimeter on every step, it will fail. The fixation material is completely secondary to the accuracy of the stability diagnosis. If the stem is loose, no cable, metal, or polymer can save it. You must revise.
Which perfectly sets up where we stand on the entirety of this issue. When dealing with true Vancouver B1 fractures, I believe precise intraoperative diagnosis combined with targeted cerclage fixation offers the absolute best balance of biomechanical stability, excellent functional recovery, and minimal surgical trauma. The Rocky cohort data, that 99% reintervention-free survival rate, proves that when the stem really is stable, preserving it and treating the bone with fixation is highly effective. Most importantly, it spares our most vulnerable elderly patients from the profound physiological shock of a full revision arthroplasty.
And my stance remains that the catastrophic consequences of misdiagnosing that stability simply cannot be ignored. The human hand is not a precise enough instrument to guarantee that a stem is perfectly fixed after the femur has cracked. When paired with the exceptional outcomes demonstrated by the cement and cement revision technique with long stems, where the fracture is mechanically bypassed and neutralized entirely, I believe we must justify a more definitive approach. It may be a slightly longer surgery today, but it ensures the patient only endures one final operation, definitively solving both the fracture and the implant stability in a single stroke.
It is clear we will continue to disagree over the reliability of intraoperative physical stress testing. The tension between trusting empirical tactile feedback versus assuming hidden micromotion is a fundamental philosophical divide in orthopedic surgery.
However, we do converge on one absolute imperative, the ultimate goal of whatever procedure is chosen. Whether you wire the femur or revise the stem, the clinical standard echoed by physiotherapy guidelines globally is early mobilization.
I completely agree. Getting the patient out of bed the day of or the day after surgery and allowing immediate weight bearing is non-negotiable. The hardware we implant, whether it is an isoelastic cable or 250 millimeter revision stem, must be strong enough to allow that patient to stand up immediately. Prolonged bed rest in this demographic is a death sentence due to pneumonia, clots, and rapid deconditioning.
Balancing surgical invasiveness against definitive biomechanical security is a profound complexity. For those listening who want to dive deeper, the clinical registries like the National Joint Registry and the Swedish Hip Register, as well as emerging biomechanical studies on isoelastic polymers, offer incredible depth into how the standards of arthroplasty repair are constantly evolving.
The data is all there, continually refining our understanding of how living bone reacts to our engineering solutions.
Indeed. When you find a crack in the foundation, deciding whether to patch the concrete or pour a whole new footing will never be simple, especially when the house is still settling and the residents inside need to walk tomorrow. Thank you for joining us.